Hi, my name is Tovy Kamine. I'm a trauma surgeon, acute care surgeon, and critical care surgeon at Baystate Medical Center in Springfield, Massachusetts. And I hold appointments as an assistant professor in surgery, healthcare delivery, and population science at the University of Massachusetts Chan Medical School. Thank you so much for listening to this talk. For the next 20 minutes or so, we'll discuss long-term percutaneous drainage and implications for long-duration spaceflight. I have no disclosures, other than that though I have managed many patients of these types that we'll discuss, I have not yet had the opportunity to do so in space. To set the stage here, let's start by talking about what exploration spaceflight means and what it entails. Cis-lunar spaceflight is spaceflight on this side of the moon. For the purposes of this talk, though, when I say cis-lunar spaceflight in the context of exploration spaceflight, what I really mean is flight to the moon, either to the surface or to an orbiting space station. Deep space means past the moon. Mostly here what that means is Mars. Among all the other problems with spaceflight, exploration-class spaceflight compounds these issues. Even for lunar spaceflight, there's a communication delay of about 3/4 of a second each way, and a 3 to 4 day trip back to Earth if evacuation is necessary, and of course, mass volume constraints for any spacecraft that do make it there. Mars makes these problems exponentially worse, up to a 22-minute communication delay each way, and a 6 to 8 month trip home, with even more limited mass and volume. So what do we know about the risks of surgical disease in exploration-class spaceflight? Well, about 10 to 15 years ago, NASA put together the IMM model of likely diseases in exploration spaceflight. There's an updated version that's currently being worked on, which will come out hopefully later this year, or next year. In the IMM model, though, there are about 30 out of 100 or so conditions, which are potentially surgical. But we're going to focus on 3 in this talk, which are really actually 2. The first one is intra-abdominal abscess, either from perforated appendicitis or diverticulitis, and the second one is acute cholecystitis or biliary colic. Why are we focusing on intra-abdominal abscesses and cholecystitis? Because NASA has been leaning heavily on the plans to do ultrasound-guided percutaneous drainage for treatment of either one of these issues. We're going to discuss 1, the prior work on this in microgravity, 2, the differences between these 2 conditions, and 3, how well ultrasound-guided percutaneous drainage works for these conditions here on Earth. So how many patients have had ultrasound-guided drainage of an abscess in microgravity? None. There is a single case report of ultrasound-guided aspiration of free peritoneal fluid by Dr. Andrew Kirkpatrick in 2002. However, as anyone who has done both an ultrasound-guided paracentesis and an ultrasound-guided abscess drainage can tell you, the paracentesis is much easier. Again, to reiterate, if any patient were to get an ultrasound-guided abscess drainage in space, it would be the first one ever done in space and the first one ever done in microgravity. So now that the bad news is out of the way, let's talk a bit about the 2 different conditions we're going to address in this talk and why I want to discuss them separately. The 2 conditions, as I mentioned, are intra-abdominal abscess and cholecystitis. I want to start off by saying we're talking about a low-risk event overall. For both of these diagnoses, we're talking about a risk of about 1 in 5 to 10,000 person-years. As such, that means that the likelihood of needing a procedure for appendicitis is about 1 in 30,000 patient-years, and for cholecystitis, about 1 in 10,000 patient-years. A mission to Mars is about 15 patient-years, so the risk of needing a procedure for appendicitis on a mission to Mars is about 1 in 2,000 missions, and for cholecystitis, about 1 in 700 missions. While I hope that we have that many missions to Mars in the next 20 years, I think it's unlikely. Why do I separate them out, though? The pathophysiology of the 2 conditions is quite different, as intra-abdominal abscess, like any other abscess in the body, is a pocket of pus and infected fluid that is walled off by the body. Once the abscess is adequately drained, either through an open approach or through percutaneous drainage, the immune system will collapse the abscess and it will heal completely. Abscesses usually resolve in a couple weeks with percutaneous drainage. Cholecystitis, though, is different. In cholecystitis, there's a mechanical obstruction of the cystic duct of the gallbladder. The gallbladder mucosa continues to secrete fluid, which, with the fixed mechanical obstruction, will not resolve until the obstruction is relieved or the gallbladder is removed. Let's get one thing out of the way first, treating appendicitis with antibiotics. The current standard of care is appendectomy, but the CODA trial in the New England Journal in 2020 did show that most patients with appendicitis can be treated successfully with antibiotics. Overall, only about 30% of patients with appendicitis treated with antibiotics in this randomized controlled trial needed appendectomy. But if an appendicitis was present, up to 41% of patients needed appendectomy within 90 days. So since it would be difficult to determine if a patient with an appendicitis has an appendicitis on a mission, let's figure that there's a 1 in 3 chance that they fail antibiotic therapy over 90 days. Not great odds if the mission is longer than 90 days. Keep in mind also, these patients needed surgery, not percutaneous drainage, because patients who presented with abscesses were already excluded from the trial. So really the risk of needing a procedure for appendicitis is slightly higher than this. And again, most of these patients would not have gotten a percutaneous drainage of the 30%. They need an operation. Let's say they fail medical management. Well, we have to hope they develop an abscess, a contained perforation. If they have an uncontained perforation, the patient will get septic and shock and die without surgical management. The other possibility is that a patient with a perforation, uncontained perforation, could develop a phlegmon, which is a collection that's undrainable and can't really be drained the way an abscess can't. Both of these happen, and they're probably about as likely as developing an abscess. If a patient does develop an abscess, though, we have two options. One is an operation, and two is percutaneous drainage. These are what the equipment lists look like. Much of an open appendectomy equipment can be 3D printed on station, and it's both light and potentially reusable. The percutaneous drainage equipment is also light, but it can't be 3D printed on station and is one-time use only. The equipment is basically the same for cholecystostomy versus a cholecystectomy, and we'll see why that one-time use limitation is so much more problematic for cholecystectomy than it is for appendicitis. So how do we do percutaneous drainage? Well, the current standard of care for appendiceal abscess is CT-guided drainage. Why is that? Well, because appendicitis abscesses are often not amenable to ultrasound-guided drainage. You can see from the CT scan here why that happens. The abscess is sometimes shielded by the pelvic bones, which block ultrasound waves and make visualization very difficult. Do we have any data to suggest this? Well, it turns out we do. Only 64% of patients who had ultrasound-guided drainage were successful, the rest requiring CT drainage. And of those patients who had ultrasound-guided drainage, about 80% have a complete response. Whereas it's important to note here that in this study, 80% of those patients had an interval appendectomy as well within 90 days. Okay, so we successfully got an abscess drain in with ultrasound guidance, and the drain actually resolved the problem. When does the tube come out? Well, that's pretty easy for appendicitis. It comes out when there's minimal drainage, which is usually 2 to 3 weeks. So how many patients is drainage successful in? Well, as we saw above, about 79% of patients who have drainage are successfully drained, but 76% of those patients end up getting an appendectomy. And the vast majority of patients, 91% in this particular study, have a pathologically abnormal appendix, meaning they either had acute or chronic appendicitis. Okay, so let's put some numbers here for a patient that gets appendicitis on admission. 70% of them will be treated successfully with antibiotics alone. Of the 30% who need procedural management, at best, 60% of those can get successful drainage. Realistically, though, it will be far less because many of those patients will not have an abscesses that can be drained. Most of those patients will have either phlegmon or free perforation. If they do, though, figure about 80% are resolved with drainage. This means that at least 14% of patients with appendicitis on admission will require surgery, and at best, 16% will be successfully managed with a drain, but would also be successfully managed with surgical drainage. So basically what we're saying is that if a patient with appendicitis fails medical management, which is a 1 in 3 chance, there's at best a 50-50 chance that percutaneous drainage is successful versus a 100% chance that surgery is successful. Seems like surgery is a better plan. Of course, I'm biased because I'm a surgeon. Let's move on though to cholecystitis. There are 2 types of cholecystitis that we see. Calculous, meaning caused by gallstones, and acalculous, meaning not caused by gallstones. The current standard of care for calculous cholecystitis is cholecystectomy. The current standard of care for acalculous cholecystitis is percutaneous cholecystostomy. What's the difference? Well, it gets back to what I said earlier about pathophysiology. The pathophysiology of calculous cholecystitis is a fixed mechanical obstruction from stones that does not resolve until the gallbladder is removed. Acalculous cholecystitis, on the other hand, is caused by edema of the neck of the gallbladder from another source, usually cardiogenic, and often after an MI or cardiogenic shock. This usually resolves as soon as the other source of illness resolves because the obstruction isn't fixed. The cholecystostomy tube usually stays in for 3 to 6 weeks, like an abscess drain, until the cystic duct is open, which can be verified by cholangiogram, and the tube is removed. Patients do occasionally get percutaneous cholecystostomy for calculous cholecystitis if they're thought to be too sick for surgery. We'll talk about what happens to these patients in particular next. So how successful is percutaneous cholecystostomy for calculous cholecystitis? Well, you can see here in a meta-analysis that the technical success with initial placement is actually close to 100%. And most of these are done under ultrasound guidance. So far, so good, right? I mean, pretty much 100% of patients can successfully get a tube into the gallbladder under ultrasound guidance. Unfortunately, the complication rates can be pretty high, up to 67% in one study. There's one problem, though, which is that, as I said, most of these patients are already too sick to get cholecystectomy. So renal failure, CHF, pneumonia, etc. may not be meaningful outcomes. Let's look more about complications we're worried about, and specifically for patients who are not too sick to have cholecystectomy with calculous cholecystitis. Almost half, or 46% of these patients, suffer tube dysfunction, and 28% require some sort of reintervention. And this is on a 1-year time scale. Okay? This is potentially a real problem when you have a single-use kit. You can also see that 37% of patients who had a per coli for calculus cholecystitis were readmitted within 90 days. Some of these were catheter calculations, but the vast majority, 30 of those 37 readmissions, which is 37% of these patients overall, were readmitted because their gallbladders needed to come out urgently. Why might percutaneous cholecystomy not work well for calculus cholecystitis? This is why. We often see gallbladders like this, full of stones, and there's really not much to drain. Really, you need to just get the gallbladder out. Another paper here on what happens to patients who don't get their gallbladders out. 19% of patients who do not get their gallbladders out in 1 year have recurrence, and 5% died from this recurrent biliary event. This is bad news for percutaneous cholecystomy. Let's talk about when the tubes come out. For acalculous cholecystitis, as I noted above, there's not a fixed obstruction, so as soon as the cystic duct is open, the tube can usually come out, usually on the order of a few weeks. Oftentimes, you can tell if the cystic duct is open because the drainage from the per coli drain will be bilious instead of clear. Remember, bile comes from the liver, and the gallbladder makes clear fluid. If there's any questions, though, we get a fluoroscopy study where we shoot contrast through the drain and ensure that the duct is clear. For calculus cholecystitis, though, the cystic duct almost never spontaneously opens because there's a mechanical obstruction from stone or stones, so the only way to get the tube out is to take out the gallbladder. A final nail in the coffin here for percutaneous cholecystomy on mission to Mars. If someone were to get a per coli on the way to Mars, that person would set several records. 1, the first successful ultrasound-guided percutaneous drainage of a gallbladder in microgravity. 2, the first successful ultrasound-guided percutaneous anything in space. And 3, potentially the longest ever percutaneous drainage of the gallbladder, assuming the patient made it that long. If the drainage was successful, which remember, the likelihood of the tube working and not requiring intervention is at best 50%, the patient will need their gallbladder out in 6 to 8 weeks, since we've seen that they often require intervention, and the longer it's in, the more likely it is to require intervention. If the drainage is unsuccessful, of course, the gallbladder needs to come out. In the final part of this talk, I want to touch on the differences between cis-lunar space and deep space. Cis-lunar space has a relatively short time in microgravity, 3 to 4 days each way, and a relatively short resupply time, and a relatively easy evacuation. I say relatively here, but we're talking about scales that are much longer than anything we've seen in terms of terrestrial resupply and evacuation since Antarctica in the 60s and really the 1800s on a broader scale. So, let's talk about recommendations. Let's say someone gets appendicitis in cis-lunar space that fails antibiotic management. Well, we have a couple options. We can attempt ultrasound-guided drainage if the patient has an abscess that's amenable to drainage. Remember, a minority of patients with appendicitis who need procedural intervention will be amenable to drainage and have successful drainage. If that works, great. We can give the patient antibiotics, pull the drain when it's no longer draining, with a return to earth in 6 to 8 weeks for appendectomy. If the drain doesn't work, we have two options: antibiotics and rapid evacuation to earth, or appendectomy on the moon. Why on the moon? Because doing surgery in the moon is going to be much easier than attempting surgery in a microgravity environment, and the data is actually pretty clear that patients who get appendicitis, who get initial treatment with antibiotics, are no more likely to perforate and die if the operation is delayed by 48 hours than if it's done immediately. On the other hand, I would posit that the best option if someone gets appendicitis on the way to or on the moon is the simplest: antibiotics and appendectomy. Why bring unnecessary equipment for percutaneous drainage when there's a greater than 50% chance that someone who needs procedural intervention will need their appendix out anyways? Appendectomy can be done under local anesthesia with 1 dose of perioperative antibiotics rather than the 5 to 14 days necessary for non-operative management. Similar to appendicitis, if someone gets cholecystitis in cis-lunar space, we have a few options. We can attempt ultrasound-guided drainage, which will probably be initially successful, but there's a 50-50 chance that it doesn't work for more than 6 weeks. Let's say we attempt it, we can get the drain in, and we'll give antibiotics for 10 to 14 days or so, and leave the drain in for 6 to 8 weeks until evacuation to earth and cholecystectomy. If the drain fails, we can always repeat attempts to ultrasound-guided drainage, limited of course by how many tubes we have with us on the ship or the moon, or we can evacuate to the earth for cholecystectomy urgently or do cholecystectomy on the moon. Or, as above, again, the best option if someone gets cholecystitis on the way to or on the moon is probably the simplest: antibiotics and cholecystectomy. Again, why bring unnecessary equipment for a percutaneous drainage when there's a greater than 50% chance it won't work? Open cholecystectomy can be done under regional anesthesia with, again, 1 dose perioperative antibiotics, no need for general, and a pretty safe environment. Deep space is a totally different animal. Deep space, we're talking about months or even years of microgravity, basically no ability to resupply and no ability to evacuate. As I said, deep space is a whole different animal. No evacuation, long time in microgravity. Someone gets appendicitis in deep space. If the patient has an abscess amenable to drainage and successful, great. Except, keep in mind the recurrence rate is 20 to 30% at a year without appendectomy. Mission to Mars is 2 years. It's a long time to hope it doesn't recur. If it's unamenable to drainage, or the drainage is unsuccessful, we're even more in the weeds. Antibiotics, hopes, and prayers are probably our best bet if we don't have the capability to perform an appendectomy in space or on Mars. We're in a much worse position than we were in cis-lunar space. If the drainage isn't successful, then we're stuck trying to do an appendectomy in microgravity. In this situation, it might be worth attempting drainage in microgravity just so that we can get to a gravity well, either Earth or Mars, to take out the appendix. But if we're on the way to Mars, the recurrence risk is high enough that we probably need surgical capability on Mars. This is even more important for cholecystitis, as we'll see on the next slide. Cholecystitis, different situation from appendicitis, remember. If we successfully get the drain in, it has to stay in until the gallbladder comes out. If the drainage is successful, we can leave the drain in until we can get the gallbladder out. The longer it stays in, though, the more likely it is to fail. So if we're looking at a few weeks of landing on Mars, we'll probably be okay. If it happens just after we're leaving Earth, though, it's a long time to hope the drain doesn't fail. If the drain fails, we can always reattempt ultrasonic drainage, or we have to do a cholecystectomy in space or on Mars. So, in summary, the pathophysiologic mechanisms behind intra-abdominal abscess formation and cholecystitis are different. While percutaneous drainage has been successfully used for both appendiceal abscess and cholecystitis, there are different issues with the two types of drains. For appendicitis and intra-abdominal abscess, percutaneous drainage may not be possible, either because the abscess can't be drained by ultrasound, or there may not actually be an abscess there to be drained. It may just be a phlegmon. Between these issues, there's probably a less than 50% chance that appendicitis that fails medical management will be amenable to percutaneous drainage, rather than requiring operation. For cholecystitis, percutaneous drainage has a high initial success rate, but the long-term success rates are not good. Again, less than 50% chance over all that percutaneous drainage will be successful on a 90-day time scale, and that operation will be required. So final recommendations. On a cis-lunar mission, percutaneous drainage, if necessary, and microgravity may be a good solution in order to get to an operation, especially if there's surgical capability on the moon. But even if evacuation Earth is required, it's probably okay. On a Martian mission, though, surgical capability is really required. Percutaneous drainage could be used in space to try to get to a gravity well to operate on, but really, the ability to operate in microgravity may be required for a Martian mission. If you have any questions or would like to speak with me, please feel free to reach out to me. My email address is my first name dot my last name, tovy.kamine@baystatehealth.org. Thanks so much for listening, and if you need any references, here they are. Thank you so much.